The House Health Policy Committee will come to order. Will the clerk please call attendance?
Chair Vanderwall.
Present.
Representatives Thompson.
Present.
Mearman.
Here.
Tisdall.
Here.
Bierlein.
Here.
DeBoer. Here. Preston.
Yes.
Schmaltz. Here. St. Germain.
Here.
Bonac.
Here.
Frisbee.
Here.
Whitsett.
Here.
Carter. Here. Whitwer. Here. Neely.
Here.
Hoskins.
Here.
Foreman. Mr. Chair, you have 17 members present. You do have a quorum.
Thank you, Madam Clerk. Representative Bierlein moves to adopt the minutes of the April 16 meeting. There being no objection, the motion passes. Today we are going to be voting out House Bill 4309 with an H1 substitute. Then we'll hear testimony on House Bill 4246. Before we read the sub, I do want to read in a couple cards here. Not wishing to speak in support of the bill, Kevin McKinney, Michigan Osteopathic Association. Not wishing to speak in support of the bill, Shane Prestin, U.S. Department of Defense. Not wishing to speak in support of the bill, Jason Lukowski, AARP. So with that, first up, we will adopt the H1 sub for House Bill 4309. It simply adds a 90-day implementation date onto the bill. Representative DeBoer moves to adopt the H1 substitute for House Bill 4309. Clerk, would you please take the roll?
On the motion to adopt the H1 substitute, Chair Vanderwall.
Yes.
Representatives Thompson.
Yes.
Mearman.
Yes.
Tisdall.
Yes.
Bierlein.
Yes.
DeBoer.
Yes.
Preston.
Yes.
Schmaltz.
Yes.
St. Germain.
Yes.
Bonac.
Yes.
Frisbee.
Yes.
Whitsett.
Yes.
Carter.
Yes.
Whitwer.
Yes.
Neely.
Yes.
Hoskins.
Yes.
Foreman. Mr. Chair, you have 16 yeas, 0 nays, 0 pass. The substitute is adopted.
Thank you, Madam Clerk. The H1 substitute is adopted. Next, Representative Preston moves to report House Bill 4309 with recommendation that it is referred to the Committee of Rules. Clerk, would you please take the roll?
On the motion to refer as sub H1, Chair Vanderwall.
Yes.
Representatives Thompson.
Yes.
Mearman.
Yes.
Tisdall.
Yes.
Bierlein.
Yes.
DeBoer.
Yes.
Preston.
Yes.
Schmaltz.
Yes.
St. Germain.
Yes.
Bonac.
Yes.
Frisbee.
Yes.
Whitsett.
Yes.
Carter.
Yes.
Whitwer.
Yes.
Neely.
Yes.
Hoskins.
Yes.
Foreman. Mr. Chair, you have 16 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. House Bill 4309 is referred to the Committee on Rules. Now we will hear testimony on House Bill 4246, introduced by Representative Green. There are a lot of folks waiting to speak, or wanting to speak, I should say, on this bill. So just a reminder to keep your comments timely. Representative Green, if you could make your way to the testimony table to explain your bill. When you are ready, hit the red button and the table is yours.
Thank you, Mr. Chair. Honor and a privilege to sit in front of the committee. Thank you, committee, for taking the time to consider this and the work that you've done previous to this committee hearing. I'm not the expert on the totality of this topic. However, you will notice I am sitting at this table alone without a specific group who has pushed for this legislation. While many organizations desperately desire this legislation, none has helped me write this. Why? Because the bill is personal to me. Please let me explain. In 1999, my wife graduated from college with her BSN from a college in Florida. From there, she sat for her state boards in Virginia. From there, we moved to Wisconsin, to New York State, and finally back to the state of my lineage, Michigan. The frustration of transferring her license to Michigan and the struggles that ensued in relation to securing a job, finishing the paperwork for a mortgage on our house because she needed a job in Michigan to get the mortgage, but she needed the license in Michigan to get the job, so to mortgage, et cetera, et cetera. What a mess. She began talking to me in 2012 about why Michigan was not part of the Nurse Compact state licensure. Fast forward to 2020 and the healthcare crisis that ensued. Nurses were heroes, and then the tides changed and many nurses became zeros. Because of the lack of the compact, nurses from Michigan had to jump through many more hoops to secure a job as a traveling nurse to fill holes out of state. Michigan also, part of my legislation package, passed legislation to allow telehealth services at this point. However, as you were here probably from other organizations today, telehealth services struggle because the person providing the care must be licensed in the state that the patient resides. The wall of licensure built around the state that keeps both licensed professionals out of our state and does not allow Michigan professionals to practice outside of our state does not serve our residents in the 21st century. This piece of legislation would solve these problems. As well, it would bring Michigan into concert with 41 other states and 2 districts. Roughly 82% of our nation is part of this compact. My wife would love to have been here today. However, she is in Virginia dealing with healthcare issues of her parents, which, by the way, means that she is technically not a nurse in Virginia, even though anyway, we can go down that rabbit hole. If you will look specifically at page 3, lines 7 through 17, you will see some of the benefits of the compact. The expanded mobility of nurse and the use of advanced communication technology as a part of our nation's healthcare delivery system. Number 4 on line 11, new practice modalities and technology make compliance with individual state nurse licensure laws difficult. Number 5 on line 13, the current system of duplicative licensure for nurses practicing in multiple states is cumbersome, and I can attest to that. And line 16, uniformity of nurse licensure requirements throughout the states promotes public safety and public health care. I would invite you to please listen to some of the organizations that will be testifying regarding this legislation. Thank you, Mr. Chair.
Thank you, Representative Green. Questions from the committee? I believe that you answered our questions, and I'm sure there'll be, excuse me, Representative Carter.
Thank you, Mr. Chair, and thank you, Rep. Green, for your testimony. Under Michigan law, licensed nurses are required to complete a minimum number of continuing education hours every 2 years, including some courses in pain management. Does the compact mandate these similar requirements?
On page 3, and I'm going to try to answer that question without, again, being a complete expert on every little detail. Page 3, line number 18 says the general purpose of this compact are to, number 1, facilitate the state's responsibilities to protect public health and safety, ensure and encourage the cooperation of party states in the areas of nurse licensure and regulation. With that, I believe there are different requirements amongst different states as to exactly what must to maintain their license. This does not usurp the states there. So if a person loses their license in Michigan, thus, they would then lose their licensure in the compact licensure. So there's a lot of technicalities through there.
Follow up, Mr. Chair?
Absolutely.
Okay, under the compact, could a nurse from a state with lower licensure standards that perhaps have no continuing education requirements practice in our state?
I guess when we talk possibilities, anything is possible, right? But I also believe when we're looking at licensure and we're looking at a professional licensure, we're looking at having an associate's degree, a bachelor's degree, a master's degree, and sitting for NCLEX. So therefore, I guess anything is possible.
Okay, thank you. Thank you.
Very good. Thank you, Representative. Moving on, we will have Amy Brown, MSN RN NEBC from Michigan Health and Hospital Association. Joining her will be Elizabeth Cutter. And again, ladies, thank you for being here. When you're ready, if you'll push the red button at the the bottom. The testimony table is yours, and we look forward to what you have to say today. Thank you for being here.
Thank you. Good morning, Chair Vanderwall and members of the committee. Thank you for the opportunity to allow me to testify in support of House Bill 4246, sponsored by Representative Phil Green, allowing Michigan to join the Nurse Licensure Compact. I'm Amy Brown. I'm the Chief Nursing Officer for the Michigan Health and Hospital Association, and I'm also a practicing registered nurse in the state of Michigan for over 23 years. The MHA represents every hospital in Michigan, and collectively, hospitals in Michigan employ roughly 217,000 individuals. Hospitals rely on our provider team members to deliver the care you and your loved ones need in a location near you. As you all know, nurses are a vital part of the care team. And as a survey of our MHA membership indicated, as of spring of 2025, hospitals in Michigan had more than 4,900 openings for nurses. That's just the need for nursing talent in hospitals and doesn't include other cares like primary care offices, schools, long-term care facilities, and the list goes on and on. An important tactic to improve our ability as a state to attract talent and make it easy for nurses to choose Michigan to practice is to join the Nurse License Compact. The Nurse Licensure Compact allows nurses licensed in a compact member state to practice in any compact state. Currently, 41 states and 2 territories are members of the compact. Michigan is one of few states that have not joined the compact, putting us at a competitive disadvantage when it comes to recruiting nursing talent from out of state. Further, for our hospitals and healthcare providers serving in our communities that border Wisconsin, Indiana, and Ohio, who are all compact states, care for patients could be negatively impacted if we can't coordinate with neighboring states to find care for patients across state lines. Hospitals continue to prioritize recruitment and retention efforts, but with the aging demographics of our state, the lack of participation in the compact hinders our ability to recruit younger nurses to replace the many nurses nearing and entering retirement. The National Council of State Boards of Nursing's biennial 2024 National Workforce Study indicates 22% of RNs nationwide plan to retire in the next 5 years. In addition to recruitment and coordination of care in our state's border areas, joining the compact would positively benefit telehealth access. Compact licensure means residents in Michigan can access more telehealth professionals in other compact states, increasing access points for our state's residents. For me, as a nurse, I'm proud to support this bill in support of my nursing colleagues' ability to easily relocate and practice here in Michigan. Thank you for your time today, and thank you in advance for your support of this important legislation.
Nothing to add.
Very good, committee. Any questions? Pardon? Oh, I'm sorry. Representative Schmaltz.
I just had one question. Thank you for your testimony. What are the major differences in licenses between states?
Well, I know that each state has different types of practice acts, and I do recall from the information that I have here, the state in which you practice, you have to abide by that. So if you were in Michigan, you would still have to follow the nursing practice with regards to the state law.
But are there specifically any major requirements from each state that would, I think what people would worry about is that nurses wouldn't have the same type of requirements that one state has over another, and one state might have, harsher or more strict requirements, and so they just want to make sure about patient safety. I think that's a.
And I would say that to Representative. Thinking about the different qualifications that you have to go through in order to sit for the NCLEX, and then also that you have to abide by in your state, that would allow for scrutiny to ensure that you have best practices and that you're following safety and quality practices to protect our patients.
Thank you.
Thank you, Representative Prestin.
Thank you, Chair. Just if you could just speak to the fact, so I worked in an ER in the state of Wisconsin. The continuing education requirements across the states, let's just say, for example, Wisconsin and Michigan, with the consolidation of healthcare systems, the continuing education that exists within those healthcare systems, as well as the state mandated continuing education, how onerous is it for a nurse to maintain dual licensure as well as the dual continuing education aspect when you're talking about border communities?
You know, I think as professionals, you know, it is at our professional obligation that we maintain competency. And, you know, I'm certified as a nurse executive, and I have further different types of education and things like that that I have to abide by. A lot of nurses are certified. So I think that if I were to be a registered nurse in multiple states, that would be my profession, that I need to make sure that I am competent to care and I need to follow all those states' requirements. So I feel like that it's very much achievable to be able to ensure that you're abiding by every state's different practices that they maintain.
Thank you, Representative. Representative Frisbee.
Just going to ask this question in a little bit different manner. We're not looking to dilute Michigan's nursing standards, their continuing education. All of that remains the same with this bill. It simply means that if you're coming in from Indiana, wherever, Wisconsin, that you have to meet the Michigan standards in order to practice here. But you don't have to go through the entire, get your license, submit, as Representative Prestin said, 2 sets of continuing education. You meet your home state, and you meet the minimums to be able to go back and forth between Wisconsin and the UP. So am I correct in that understanding? We're not diluting our state standards?
Correct.
Thank you.
Thank you, Representative. Representative Bierlein.
Thank you, Mr. Chair. So we've been part of the compact or license reciprocity for physicians for quite a while. Michigan requires 150 hours for physicians over a 3-year period in continuing education, but like Ohio and I think Indiana are both at 75. But that's been in this state for a while now. Have we seen physicians from other states just not perform the job here because they don't have the same licensing requirements in their state?
In terms of the Interstate Medical Licensure Compact, we actually sunsetted that on accident, I would say, just about a month ago. So it does impact a number of folks. You're right that there's probably 3,500 or so physicians that participated in that compact. It's not my understanding that people have not met the standards here in Michigan.
Thank you.
Thank you, Representative. Representative Thompson.
Thank you, Mr. Chair. As a nurse who just renewed her license in February, because I do renew every 2 years, can you talk a little bit more and explain to the committee members and those in this room about the continuing education credits? Right now in the state of Michigan, there's no requirement for pain. There's just a requirement that you have taken a sex trafficking continuing education credit, and we are required by the governor to do implicit bias training, but then we have options as to the other CEUs that we take. Can you talk a little bit more about that?
I at this time, I'm not exactly sure. Could you, I'm not sure what the question is.
When you renew your license in the state of Michigan, you don't have to particularly take a continuing education credit related to pain in order for you to get your license. So we have multiple topics and multiple things that are considered continuing education units in order to renew your license. Can you talk about those, the process of renewing your license in the state of Michigan, what's required? And then I was going to lead into, wouldn't it be a hospital or a nursing facility or the place that you are employed to ensure that you meet the standards of Michigan nursing? And if you do not, then you would ultimately not be getting employed in the state of Michigan based on your employer hiring you to meet those standards.
So I'm not an expert in this topic.
Okay.
I can tell you as a registered nurse what I know,
Yeah.
and that I need to meet the requirements of getting my own contact hours. I do know that it is very easy to obtain contact hours. In fact, I get a flyer in the mail about every other week. If I pay $49, I can get all of my contact hours in just a little amount of time. Professionally, I don't think that's the right way to go. I also, as I stated previously, am certified, and so my certification really entitles that I have to have more than 25. So I think that The minimum standards to achieve your contact hours are very vague. It has to be through a continuing education provider, and there's a lot of rules around those different types of providers. With regards to ensuring that you have met the continuing education hours, I believe from my practice that the hospitals do not look into that. They only make sure that you're licensed. So they're not looking to see what you've completed with regards to continuing education. They're only checking to make sure that you've renewed your license.
And to Elizabeth, does your members offer continuing education credits through the facility?
I don't know that off the top of my head, but I could find out for you.
Okay, thank
Yeah,
you.
I'd be happy to do that.
Do hospitals?
You may know that.
There's many hospitals that offer continuing education credits. It depends if they're a provider, so if they're able to do that. But a lot of organizations throughout the state, you have to go through a pretty extensive process to be a provider to issue those credits. And nurses can get credits through many different types of providers throughout the country.
Thank you, Representative. Representative Carter.
Thank you, Mr. Chair. I'm going to hold my question to a little bit later.
All right, very good. Just one last question. You said there's 41 states that are in this compact currently. Again, what was the shortage in nurses the figure I didn't write that?
For Michigan, the survey stated that there's 4,900 openings for looking for registered nurses, and that's just hospitals alone.
Very good. Thank you both. I appreciate it. I see no other questions. Thank you for your time. Next up, we have Dr. Leah Small, Michigan Association of College of Nursing. Doctor, thank you for being here today. When you're ready, you've got the light. The testimony table is yours.
Thank you very much, and I'm very happy and pleased to be here and to represent the profession of nursing. Good afternoon, Chairman Vanderwall, members of the House Health Policy Committee. Oh, by the way, I'm the Dean of the College of Nursing at Michigan State University, hence the green and white. Thank you for the opportunity to speak to you today in support of House Bill 4246. My name is Lee Small. I'm the Dean. I already said that part. I'm here representing the state's academic voice on behalf of Michigan Association of Colleges of Nursing, or MACN, an organization that represents 30 Michigan schools of nursing that educate students at the baccalaureate and graduate levels. Data from 23-24 indicate that a combined enrollment in our programs was greater than 12,000 students and graduated over 4,000 new nurses ready to practice and enter the workforce after taking successfully their NCLEX examination or certification examination. I've been a nurse for greater than 40 years, so we're not going to talk about that very much. I've been a pediatric nurse practitioner for over 35 years, and I have served as a nurse educator and a nurse scientist for greater than 25 years. And I'm here today to offer nursing education's support of the Nurse Licensure Compact legislation. Currently, there are 4.9 million registered nurses in the United States, making nursing the largest healthcare profession, which is nearly 5 times that of the physician workforce, and the largest component of the healthcare workforce. Nursing is also Michigan's largest profession, with over 175,000 registered nurses licensed in our state. House Bill 4246 would authorize Michigan to join 42 states and 2 territories that include Wisconsin, Indiana, and Ohio to be a part of the Nurse Licensure Compact, to allow nurses to choose the ability to practice in other compact states without obtaining and maintaining multiple nursing licensure. The legislation would permit a nurse to practice in their home state as well as other nursing compact states while maintaining their primary state of residence. This bill would reduce regulatory barriers while maintaining quality standards for nurse licensure, providing cost savings, which I think you've heard a bit about before, and more flexibility for nurse educators, nursing students, patients, nurse educators that provide clinical instructions to students out of state would no longer have to maintain multiple out-of-state licenses. The compact could also help address nursing faculty shortage by allowing nurse educators to provide instruction via distance learning in other compact states without maintaining multiple out-of-state licensures. So, for example, the psychiatric mental health nurse practitioners would have to have a Michigan's state of nursing license as well as if they belong in a compact state. Additionally, states in need of nurses or healthcare provision would have the ability to host travel nurses or have telehealth options, which the first gentleman talked about, available to constituents, which would increase availability of nurses to come to Michigan and increase access to care, which we know is a problem. I believe right now there are 3 million Michiganders who do not have access to primary health care services. Graduate students who are already holding nurse licensure can have clinical placements across state lines, which would reduce the burden on them finding clinical placements, which is currently a bottleneck in developing more healthcare providers. Cost savings to patients and nursing alike by increasing access to nursing services more efficiently through telehealth, for example. And the COVID pandemic has shown us how compact states had greatly benefited by allowing for quick mobilization of healthcare professional workforce due to provider shortages in some states compared with others. So please support this legislation and join in the majority of other states. Thank you for the opportunity to speak.
Thank you. Any questions from the committee? I have just, Representative Carter.
Thank you, Mr. Chair, and thank you for your testimony. I'm just wondering, being from the academic persuasion where you're coming from, have you done a study on the impact of what the compact could potentially do to the existing workforce of nurses?
I have not done a study, and I'm not aware of a study. I believe we have NCSBN representatives here today, and perhaps they're aware of it. NCSBN, for those of you who don't know, is the organization that offers the national required accreditation for all nurses to pass before they're considered to be registered licensed nurses. And then they're licensed within their particular state. So I am not aware of that. I can tell you I've been a nurse in 5 different states. It is very onerous for me to go from one state to another and then make decisions, because there's great cost, because I'm not only a registered nurse, but I'm an advanced practice nurse. I have to pay for both of those, and I have to make decisions about which states I'm going to continue to hold licensure in. So it is a barrier to that. And because I've taught in hybrid online situations as well as in-person classes, it's very difficult to find faculty in order to do that education. I came from Arizona at one point, which is a highly rural state, much like Michigan. So,
thank you.
Thank you. Out of the 4,900 graduates, or 4,000, I believe you said, right?
4,000. Mm-hmm.
How many of them choose to leave the state of Michigan for employment?
I can only speak for Michigan State. For Michigan State, we have over 75% of those students who are educated undergraduate students who stay in the state of Michigan. The other percentage lose or decide to go to other places. But I will tell you that it is onerous for organizations to have nurses come into Michigan because they want to continue to hold their compact license, and then they have to get licensed here.
How expensive is that license?
Oh, I don't know off the top of my head.
I'm sure somebody can answer that for me.
But it's hundreds, and then when you get in multiple states, it's
Right.
hundreds. And
Okay.
then if you prescribe, there's other costs associated with it.
Very good. Thank you. Any other questions? Seeing no other questions, thank you very much for being here.
Thank you.
Next person wishing to speak and opposing the bill is Michelle Mahone, RN, National Nurses United. Is that correct? Oop, I'm sorry. I did. I jumped cards. I apologize. She was so far ahead. Katie, both and Aaron McCormick, Michigan Nurses Association.
Good morning, Chairman Vanderwall and the members of the committee. Thank you for the opportunity to speak today in opposition of House Bill 4246, the Nursing Licensure Compact Bill. If it pleases the committee, we would like to testify back-to-back so we can answer questions collectively. Thank you so much. My name is Aaron McCormick. I am a registered nurse at the University of Michigan Health or Michigan Medicine in Ann Arbor. I have been a registered nurse for 11 years. I am also the Vice President of the University of Michigan Professional Nurses Council, where I represent over 7,000 nurses working in the system. I also serve on the board of directors for our state union, the Michigan Nurses Association. M&A, Michigan Nurses Association, is the largest union of professionals, largest union and professional association representing registered nurses in Michigan. I just want to highlight a few of my main concerns about the Michigan joining the Nursing License Compact. I know it may seem surprising to have a nurse say that we don't want the compact, but it is because I am a nurse, a proud homegrown nurse, and committed to our state that I oppose it. A primary concern for me is the fact that with the compact, nurses from states with lower standards than Michigan could work here. I worked hard for my Michigan nursing license. I also worked hard to maintain the requirements to keep my Michigan nurse's license. That includes completing at least 27 contact hours of continuing education every 2 years, which includes mandatory pain, implicit bias, and also sex trafficking, and it's constantly being reevaluated. Some compact states, including nearby Indiana, have no continuing education requirements for nurses. This is really worrisome because nursing is a constantly changing profession. We have to keep up with new information, new practices. I'm glad Michigan has high standards. I want to work next to nurses who have met the same high standards that I have, not the least common denominator. Another concern I have is the effect of the compact on our nursing workforce. If nurses want to practice nursing in our state, they should get a Michigan license. It's that simple. There's always already a process in place for that. Nurses moving to Michigan can be licensed in as little as 48 hours these days. This is what we want. We want nurses to move here and be committed to working here long term. I respect travel nurses, and you might say we nurses should be grateful to get whatever help we can get, but at what price? Nurses who come and go do not help build the stable nursing workforce that we need. We train them, they leave. Or they stay on because it's cheaper for the employer. They take jobs that we would rather see go to permanent staff nurses. In my experience, having a team of nurses provide care makes for a better, safer experience for our patients with better outcomes. And to be honest, I do not like the idea of my job possibly going to a temporary nurse who is not committed to our state like I am. I am concerned that the compact is being treated like a simple fix to a problem that requires multiple approaches. There is no doubt that there is a nursing staffing crisis in our country. We need to understand, though, that a staffing crisis and a staffing shortage are not the same thing. Every nurse knows other nurses who have left the bedside or even the profession altogether because hospitals make the working conditions too hard. There are enough nurses in Michigan. It's that not enough nurses want to work under the conditions that the hospital industry has created. In 2023, University of Michigan made a study. Nearly 40% of nurses surveyed said they plan to leave their job within the following year. 40%. There is no doubt that Rep. Green has the best intentions with his bill, and we applaud his good intentions. We share his concern about the state of nursing workforce and its effects on health and safety of the residents of our state. But the compact will bring more problems, not answers. As far as bringing in more nurses, it seems like most Michigan nurses who want the compact want it because they want to practice in other states. How will exporting nurses help our state? Let's keep the standards high here for every nurse. Let's keep oversight of the nursing profession within Michigan, and let's keep working together on real solutions to the nursing staffing crisis, which includes safe RN to patient ratios, limited mandatory overtime, and protects us against workplace violence. Thank you for your time.
Thank you.
Good morning, Chair Vanderwall and members of the committee. Thank you for this opportunity to speak here today. My name is Katie Pontifex, and I am a practicing registered nurse of 16 years and the Associate Executive Director of Healthcare Practice, Policy, and Strategic Initiatives at the Michigan Nurses Association. I'm here to ask you all today to oppose the proposal for Michigan to join the Nurse Licensure Compact, also referred to as the NLC. I, too, share the experience that Rep. Green shared. I know personally the frustrations of having to apply for different licenses throughout different states. However, while the NLC is sold as a way to increase access and enhance public protection, a deeper examination reveals serious risks. If adopted, Michigan would compromise patient safety, weaken our professional standards, and surrender our regulatory authority to out-of-state decision makers, a trade-off that Michigan's patients, nurses, and healthcare employers simply can't afford. The NLC forces Michigan to recognize out-of-state licenses without the ability to independently verify a nurse's education or up-to-date disciplinary history. This is not about efficiency. It's about stripping Michigan of its ability to set and enforce standards appropriate with our state's needs. A strength in Michigan is that we have a state board of nursing that is nonpartisan and composed of 16 nursing professionals at every level of practice and education. The 8 remaining seats are for members of the general public. These 24 members are tasked with ensuring that public safety is at the forefront of the care being delivered to Michigan constituents. Michigan currently maintains its autonomy of oversight for those seeking a Michigan nursing license. But by joining the NLC, Michigan would be required to trust states with very different and sometimes dangerously lower standards for nursing practice and discipline. To Rep. Preston's question earlier, every state follows a different scope of practice. For nurses, the onus is on the nurse to know the laws in which the state they are practicing. And if they're not reading into this and keeping up on the different changing laws throughout the state and regulations, it not only puts them at risk with their license, but our patients as well. This is especially concerning when it comes to telehealth. If I'm a registered nurse in Arizona but providing care for a Michigander, I need to know the Michigan laws in which this Michigander is seeking care and what I can provide to them. We should not outsource patient safety. We should not gamble with the lives of our residents. The recent Operation Nightingale investigation uncovered the sale of 7,600 fraudulent nursing diplomas and transcripts. Of those 7,600 individuals, approximately 2,400 passed the national licensure exam, allowing them to gain access to the healthcare workforce, having never completed proper nursing education. Fraudulent nurses secured licensure in at least 23 different states, many of which who are part of the NLC. Some of these fraudulent nurses made their way to Michigan. When alerted, the Michigan State Board of Nursing was able to step in, assist with those investigations, and deal directly with those individuals, issuing disciplinary action where appropriate. As Operation Nightingale proved, under the NLC, a nurse involved in fraud in another compact state could easily obtain a multi-state license, likely already has one in hand, and practice in Michigan before our regulators knew there was a problem. This situation underscores the critical importance of maintaining robust state-level oversight in nursing licensure. It also highlights the potential risks associated with the NLC, where reliance on other states' regulatory standards could expose Michigan patients to similar fraudulent activities. If Michigan joins the NLC, we create a new open door for fraud to harm our patients. Proponents argue that the NLC will solve staffing shortages. This is very misleading. Let's be very clear. The NLC does not create a single new nurse. It simply shuffles existing nurses around, making it easier for them to move between states, often in response to higher paying or lower demand markets. If a nurse wants to travel within the state of Michigan, all they need is their Michigan license. This legislation is meant for nurses looking to travel amongst different states. My staff and I field multiple phone calls a week asking us why the MNA opposes legislation such as the NLC. Before we answer, we ask the caller, why would you like us to support it? And the answer is the same 100% of the time. Because our nurses are looking to leave Michigan. With the NLC, we would simply be holding the door open as they go. Michigan's underserved communities and rural hospitals, like those in Michigan's Upper Peninsula, will not benefit from this. In fact, evidence from other NLC states suggests that urban centers with more financial resources attract nurses away from rural areas, worsening, not improving, the staffing crisis. We might get lucky, and our beautiful Michigan summers may attract some nurses to the state temporarily, but Michigan has brutal winters, and they will leave for warmer weather. We aren't looking for seasonal staffing. If Michigan wants to strengthen its healthcare workforce, we should invest in local nursing education, retention strategies, safe staffing laws, and professional supports, not hope that an influx of out-of-state nurses will solve our problem. The NLC favors large multi-state health systems and staffing agencies who benefit from easier access to a mobile temporary workforce. This undermines Michigan nurses' bargaining power, contributes to wage stagnation, and actually encourages reliance on traveling or agency nurses over building a strong, stable healthcare team in our own community. It's not a coincidence that major hospital corporations are amongst the loudest proponents of the NLC. Michigan should protect its healthcare workers and invest in permanent solutions, not temporary patches that leave patients with less continuity and nurses with less security. The NLC reduces transparency and weakens Michigan's ability to act swiftly when a nurse poses a risk to patients. When a nurse's license is revoked or suspended in another compact state, it may take time, up to several months, for Michigan regulators to be notified or take independent action. In looking for research on this, what I found was that on average, NLC states are approximately 6 months behind reporting for disciplinary actions. It is likely that way across the United States, but that was specific to the NLC. Michigan's patients deserve direct, accountable protection, not a distant bureaucracy's second-hand assurances. The Nurse Licensure Compact is a bad deal for Michigan. It weakens patient safety protections, it opens the door to fraud, and it undermines Michigan's professional standards and workforce stability. We should not rush into surrendering our sovereignty over nursing practice based on promises that the NLC simply can't currently deliver. I urge you to stand with Michigan patients and nurses and reject the NLC. Thank you for your time and consideration.
Good morning. Thank you for the time. My name is Michelle Mahan. I'm a registered nurse, and I'm the Director of Nursing Practice with National Nurses United. NNU is the largest professional association and union of registered nurses in the United States. I'm here today to oppose the Nurse Licensure Compact. Our national experience should provide valuable insight to you as you make this important decision. First, as many people here have been talking about the supply of nurses in the United States and that concern, we know, there are nearly 1 million registered nurses who are licensed and able to work in this country who are choosing not to work as registered nurses because, as we heard my colleague explain, working conditions are the primary reason that nurses are choosing to leave direct care where we need them. The Board of Nursing is the regulatory authority that is put in place to make determinations about the practice of registered nursing, and it is a public entity. It is important to know that joining the Nurse Licensure Compact would require Michigan to cede control over nurse licensure to an interstate commission where it would have little authority. Under Compact, Michigan must give up the power to regulate nurse licensure to the Interstate Commission of Nurse Licensure Compact Administrators, or the Commission. By entering Compact, Michigan would be bound to the Commission's power to promulgate rules that, quote, shall have the force and effect of law. Moreover, it would be unfairly, Michigan would be unfairly underrepresented on this commission. Compact allows only one appointment for Michigan to the commission and only one vote, even though Michigan has more licensed registered nurses than many of the other states. Fundamentally, the Compact is anti-democratic and lacks the transparency necessary to ensure safe patient care for Michiganders that the nurses here are trying to protect. The other important element is, as we heard in the example of the Nightingale fraud degrees, joining the Nurse Licensure Compact would take important funding away, divert funding away from the Michigan Board of Nursing. making them less able to respond to these types of situations and have less capacity to oversee nursing education in this state. Many have talked about the role of the potential of employers to provide education. This is also, the employers do not regulate nursing practice. They may or may not choose to provide continuing education that complies with the standards of the State Board of Nursing. We have already heard that many states who are in the Nurse Licensure Compact have 0 requirements for continuing education. This is really important for patient safety. You've heard about other types of certifications, et cetera, and those, as nurses, we take pride and invest in our education. I want to talk a little bit more about the workforce. We've heard about the benefits of access and telehealth, and we learned and we heard about the COVID-19 emergency. We know that during the COVID-19 emergency, that contrary to arguments in favor about providing a robust workforce, that during the pandemic, federal data show that hospitals in compact states reported a higher percentage of days with critical staffing shortages every year from 2020 to 2023. So it did not resolve this emergency. So this is not the fix to the problem. The workforce here, what we liken it to, is like NAFTA for North America, not for North America, for the United States and the territories, outsourcing good paying, solid and reliable registered nursing work to states with lower working standards, labor standards, and wages. I want to emphasize that as nurses, our working conditions are patient care conditions. Additionally, through telehealth, a nurse, as we heard, is accountable to the State Practice Act that they are practicing in, even if they are in an interstate compact. However, in a telehealth environment, a registered nurse may be caring for patients minute to minute from many states at one time, needing to know and understand all of the different states and dynamics from phone call to phone call, from video visit to video visit, really with no understanding, no cultural competency of the environment in which the people live and work and the social determinants of health that affect Michiganders. So this is another important consideration. We'd be happy to provide additional information and answer any questions, but emphatically, nurses across this nation believe that the system, through regulating nursing practice, through the public process of and democratic process that exists through the boards of nursing, this rulemaking process and the discussion we are having today is vital to keeping patients safe across this nation and here in Michigan. So I want to thank you and emphatically oppose the adoption and entry into the National Nurse Licensure Compact.
Thank you. We do have several questions. We'll start with Representative Meerman.
Thank you, Chair Vanderwall. Do you have examples or know of examples that indicate negative health outcomes for patients concerning physicians? We just went through 5 years of a compact with physicians.
No, I don't. I did not follow the physician compact, so I'm not aware of any health outcomes for that specifically.
Thank you.
Thank you, Representative Thompson.
Thank you, Mr. Chair. And I must do a clarification. When I heard Representative Carter talk about pain management, I misunderstood. I thought you said 25 hours of pain management. That's why I asked the question, trying to get them to come out and say, no, it's 2 hours, but that didn't come out. So I'm very aware of that. Thank you for bringing that up. I just got to be honest. I think that we should just be honest. And Mr. Chair, if I may, we have many nurses in the state of Michigan, from licensed practical nurses to RNs to varying degrees to nurse practitioners. We're representing a lot of people here in the state of Michigan. And I know right now we have the union nurses present in the room that are very much opposed to this. They've made it clear. I know that you are concerned about worker rights, about your patients being protected, about wages, but we have to use all of our tools, and that's what I'm asking people to do. Use all the tools. I actually co-sponsored legislation last term to make safe patient ratios and to work on that. I think that we don't have to look at this as this is a one-size-fits-all. If we do this compact, we're going to make Michigan the best state for nurses, the best state for patients. I think it's one thing that we need to do or look at in order to make sure that we're meeting our safe patient ratios. And let me just say, when I went into nursing, my mom is a nurse, and I always wanted to be a nurse like my mom. And I never got to do that in my younger years because I was raising children and I stayed home with them. But I got to go back to nursing in my late 20s, go to school to become a nurse. And I always wanted to be that superhero that was a nurse, because in going to school and listening to my professors and doing my clinical hours, I knew, I'm just going to be honest here, I knew what I was getting into. I wanted to be that superhero. I wanted to be that person that knew that I could not leave my patient because I was abandoning my patient. I wanted to work the extra shifts. I wanted to go the extra hours. We know this as nurses, and that's why we go into this, because we were born to do this. And I just wanted to say that in front of this committee and to all the committee members that however this vote comes out and whatever happens with this legislation, it shouldn't be choosing to stand with nurses, choosing to stand with patients, choosing to stand with democracy. It should be about doing everything that we can do to make sure that our patients are getting very specific patient-centered care, and that our nurses are being compensated, taken care of. And just really quick, I'm just going to ask this question. So out of all of the nurses in the state of Michigan, what is the percentage that the nurses union represents? Of all the nurses that are RNs, because you do not advocate or work with LPNs, correct?
We advocate, but we do not represent any.
You don't represent LPNs. So how many RNs do you represent? What is the percentage of Michigan nurses that are represented by the Nurses Association?
I'm going to own that math is not my strong suit, so I would need my calculator. We represent 14,000 registered nurses in the state of Michigan, including advanced practice nurses. So throughout the levels of
it's 12%. It's
Thank you.
12%. So the Michigan Nurses Association represents 12% of nurses in the state of Michigan. But this compact would allow for RNs to travel between states and LPNs to travel between states. So I support what you guys do. I'm going to continue to work on legislation coming at it from a nursing standpoint, that we need to have all the things that we were trying to work on last year. But I urge everyone in this room, last time this got brought up, or things got brought up, it became a fight between the union nurses and the non-union nurses. And I think that we're better than that as nurses, and we need to keep it about the patients and the nurses and not just about a union thing or a democracy. Thank you, Mr. Chair.
Mr. Chair, may I respond? I agree with you. I appreciate your statement and your questions. I would like to clarify, I represent I actually oversee the professional side of the organization at MNA. So my testimony was truly coming from not as a union nurse. I have worked as a union nurse. I've also worked not as a union nurse. I do understand the union challenges that we would face with the NLC, but I was coming at it from a professional standpoint with my concerns of continuing education and different practices, and really, truly, the onus that is the burden, honestly, is put on the nurse to make sure that they know, and I understand that it is a responsibility they are willing to take on, to be sure that if they have a multi-state license, they are also knowing the rules and regulations within the states in which they are practicing. So I think, to your point, that there are multiple solutions to our staffing crisis. Absolutely. I would appreciate a conversation even regarding the compact. I think, if nothing else, the Michigan Nurses Association, if nothing else, it's opposed as written as well. I mean, we strongly do oppose this legislation, but either way, I appreciate that Representative Green took this on as a personal, fix that he was wanting to do. But we could be part of this conversation, and as it's written, there are many loopholes to the compact that would present a risk to our patients here in Michigan, and I think that's more than anything what we would like to see.
Thank you for the honesty and for the conversation. I will continue the conversation with you.
We always appreciate conversations with you, Rep. Thompson.
Thank you, Representative. We are starting to get tight on time a little bit. We've got 4 more people that want to speak. We have several questions to go, so we'll go with Representative Whitsett.
Hi, thank you for your testimony. I have like so many things swirling in my head right now. Just based on personal experience of my sister having a brain aneurysm and being in ICU, I watched the staff that's hired by the hospital and the quality of care that they're able to give, and the traveling nurses. And then I watched the people who just came straight out of school or through a service, some type of service, and yeah, agency. And I had to like literally show the people from the agency how to drain the fluid off my sister's brain. I saw, you could see the differences, and you could see the differences in the actual traveling nurses. And I would say, out of 5 of those traveling nurses, you would get 1 that was great quality and measured up to the people that worked at the hospital. There's already an issue with making sure that everything is staffed properly and that the nurses that are there that are employed are not overworked. I have a huge concern about the pay equity. You have people that are traveling nurses that get paid way, 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 way more than the nurses that are actually employed by the facilities. So I have a lot of issues and concerns, and like I say, just from personal experience and what I've seen, I'm more dedicated and there for my nurses that are here in Michigan. And that's where I have to be at. Thank you.
Mm-hmm.
Thank you, Vice Chair. Representative Beerlane.
Thank you, Mr. Chair. Do any of you know how long has the compact existed?
Oh, sorry, I guess left it on. Yeah, so the Nurse Licensure Compact has undergone several iterations, originally in the late 1990s. Only one state for many years, so it has taken decades for states to join the compact because of serious concerns over those times, and many of those concerns remain, right? They have done some some modifications based on certain states' concerns again and again. One of the other big concerns is over the years, the fees that get taken from, that it costs for the state to pay to the National Compact is increases, right? And they can raise that without a vote from y'all. So that is really concerning. So really starting in the early 1990s, but only with a very small number of states, but has taken over 25 years to coax and persuade people to join this compact, which still is problematic and flawed and not modifiable. So we can't tweak it. We cannot tweak it. So, making it the best state, the best compact state is not an option. So that, since the early 90s, but only more recently, has taken over 25 years for states to join the compact.
If I may, Mr. Chair, have any states left the compact after joining?
Not that I'm aware of. However, I think it's particularly onerous to leave.
How so? How so?
Well, when you put structures and systems in place and you build industry dynamics around a model that it is dependent upon, not investing in infrastructure, you reinforce a dynamic. So I think that's it. Additionally, you would need to, come back to the legislature and we would be here in this process again over and over. So really, you just can't just be like, it's not working for us, we want to opt out. Right, we have to come back through daylight, even though they can modify the compact really in a, through this quasi governmental process.
We do that every day. We come up with new ideas because something isn't working properly. So I'm just not sure that.
But I'm sure. But the thing is we're here. You're open in a public committee, You're having a hearing. We're here testifying. We're here representing. We're having a discussion. This is not happening through the compact process on a vital public safety issue. So, there is significant variation in nursing practice from state to state when it comes to things like how we delegate care to others, the types of limitations on those other types of care providers. Those are things are really important to understand and know when you're providing care to patients in your state. So that's.
Just one more, if I could. Sorry, do any of you know how Michigan ranks nationally on health outcomes? Just, are we at the top, at the bottom, in the middle? I'm just curious. There's so many states participating.
We can get you that information,
Thank you.
but no, we don't have it with us.
Thank you.
Very good. Thank you, Representative. Representative Carter.
Thank you, Mr. Chair, and thank you all for your testimony. I have to echo the sentiments of Minority Vice Chair Whitsett. Okay, we had an experience in 2011 where one of our children lost control of his motorcycle, and it took him a week to die. He had a TBI, and it took him a week to die. And the reason I'm bringing this up is because during that week where we were hoping and praying for a miracle and watching his brain swell, the nurses that were around not only comforting Christopher, but comforting the family who was there. And I guess the point that I'm trying to bring in is that nurses are more than just something that's transient, something that you can do a quick fix with. Sometimes nurses are the people that are there to comfort you and console your family in periods of time where, we can't handle it. So what I'm looking at this is, and I understand that we have a crisis, a shortage, yes, and we need to do something about it. But let's also consider, and I did ask the question earlier to the other groups, the proponents of the legislation, what impact would the compact have on the existing workforce, the existing nurses, the ones who held my hand, the one that sat there while I watched Christopher take his last breath. This is what we are risking losing if we don't handle this with care. Nurses are more than just someone that comes in and give you a thermometer when you have a fever. A lot of times they are the ones who help you through a crisis. And I thank you for the opportunity to share that with you.
Thank you, Representative. Representative Prestin.
Thank you, Chair. One of the programs, like you were talking about before, turning around and reestablishing something, we just did that with the MyMedic. We realized that the National Registry was not the one-size-fits-all for everything, and we just last session voted to reinstate the Michigan-based medic program, and that's undergoing right now. So to say that modifications cannot be made, and that the compact doesn't have modifications that can be made within it regarding partial implementation, things that are specific to the state of Michigan, is just untrue. Now, when this relates to the Upper Peninsula, we're talking about just not within my district, but across the UP, we're talking about 3 healthcare systems that have a Wisconsin-based footprint. Aspirus, and in Illinois, OSF has an Illinois-based footprint. And then Dickinson, which is Marshfield now, has a Wisconsin footprint. When these hospitals, have any of you ever worked on a border community? Okay. When we're talking about leveraging workforce, especially when we're facing conditions like diversion, which I've been on at the hospital that I worked at, it's not pretty. And the reason that we were able to work through that diversion is because Menominee County, Southern Menominee County, uses a Wisconsin-based hospital. That Wisconsin-based hospital was able to move staff out of the Aurora facility in Green Bay up to our facility in Marinette. The same thing would hold true with Aspirus and would hold true with Marshfield. Now, these are all border hospitals that take both Wisconsin as well as Michigan patients. So requiring nurses to carry dual licensure is onerous in nature. It's incredibly costly. And the fact that it only takes 48 hours for them to get their license, it's just indicative of the fact that the compact is is practical in this, because if it's only 48 hours, you're not finding out if this is a fraudulent license in that 48 hours. You're simply confirming that the license existed in the other state, confirming it, hoping that you don't get caught up in any of the loopholes and that you actually get your license within that 48 hours. And even at that, you're still looking at a hospital that's facing a dire workforce shortage, poor patient outcomes. And at the end of the day, for me, this is all about patient outcomes and how the patients are going to fare, as well as everybody should be thinking about that. These types of artificial barriers have been systemic in Michigan. They existed in fire services. They extended into EMS, physicians. You know, this is protectionism at its finest. It's just another day in Michigan, another aspect of protectionism, I believe, for the State Board of Nursing and other interests. These are the kinds of barriers that are preventing healthcare in Michigan from moving to the next level, recognizing that these are all individuals, they're professionals, they've gone through the training, they've gone through the school, the testing, as well as the continuing education that is not only required by the state, but also whatever health facility that they work in. And I can tell you that the facility training and the continuing education required at the facilities that you work at is sometimes worse than the state's continuing education. So between all of the licensure issues, the costs, and the continuing education, the UP is never going to see its way to a robust nursing environment unless we do embrace compacts like this and make them work.
Yep, absolutely. Now, as I said before, we have 4 more people to speak.
I'll be brief.
We have 2 more questions that we're going to have, so I'm going to ask that we keep it short. Out of courtesy to the other people that are here to speak, go ahead with your answer, please.
Sure. With all due respect, sir, I do appreciate what you're saying here, but you know, I want to be clear that the compact is a contract. Article 10, Section F of the Nurse Licensure Compact that you would be signing to pass and join says, no amendment to this compact shall become effective and binding upon the party states unless and until it is enacted into the laws of all party states. So it is not modifiable. I want to be clear on that. You may choose to leave the compact, as you said, but you may not amend the compact unless and until all party states have agreed to modify it, and which you would not necessarily have a direct vote. The legislature of Michigan would not. It would be the Nurse Licensure Compact administrators who get that vote, not yourself. So working on the border, we want to talk about the fact that there are other states considering options besides this Nurse Licensure Compact, which would be democratic, transparent, and allow cross-state, particularly the District of Columbia, is examining alternatives to do a tri-state compact that would be fair, just, and democratic, and uphold practice standards across that region. So I just wanted to be clear that this compact is not modifiable.
Unfortunately, though, the UP only borders one state, and that's Wisconsin. They are a member of the compact, and it would give us the ability to immediately leverage workforce out of that state where 3 of our systems are located.
Thank you, Representative. Representative Frisbee.
Question about the travel. You had said there's travel nurses, and we've all seen them if we worked in healthcare. What percentage of those traveling or working in Michigan are Michigan nurses traveling within Michigan? Do you have any? Yeah.
Right, thank you. We can get that information for you.
Okay.
And we can look into it. Personal experience, I think Aaron and I would share that when we were at the bedside during the COVID-19 pandemic, we saw a lot of our colleagues leave staff positions or drop their hours to per diem or part-time so as to take travel positions throughout the state of Michigan, getting paid staffing crisis pay, as Rep. Whitsett referred to earlier.
So at your facility, do they use travel nurse?
Yes.
And was that a negotiated issue with the union?
So when we have travel nurses, it is parts of our contract. They're temporary workers, and we have temporary workers built into the contract. So
it is a negotiated issue. Okay, thank you. And then with the Nightingale issue, this happened prior to this compact, where were those folks licensed at? In what state did they come from?
They all came from 3 different nursing programs in the state of Florida. It didn't break down where they were licensed because you can get your degrees, transcripts in any state and then cross-state license because we all take the same national licensure exam. That did say that they ended up licensed in 23 different states, many of which were the compact.
But this issue began in Florida.
It
the
did.
State of or the state of Florida not doing their due diligence to issue a state license, not a compact issue, right?
They're part of the
state,
compact.
I get that, but the state of Florida had the onus to prove and verify that they were duly trained and certified as nurses, and it sounds like they didn't do that. Not
If
the
they
compact.
if they were credentialed in Florida, if they sat for their NCLEX in Florida, ultimately
Somebody
we all get
gave them
something.
a license.
Yes,
is my
and
point.
we wait for something called an ATT,
Yep.
like notice that we've met criteria to sit for the test. That goes through the NCSBN.
Okay, thank
So
you.
somewhere, you're right, somewhere somebody dropped
Yep.
that ball.
Thank you.
Thank you, Representative. Last question for you guys. Minority Vice Chair Whitsitt.
Okay, excuse me. I know we talk about the nursing shortage, and I know that COVID changed things, and so we needed a lot of help. The way I'm kind of seeing this, and when I'm having conversations with people who are in the administration who have to do the interviews and bring people in, they're bringing people in from these agencies of these traveling nurses. So I'm trying to understand, and you represent them, so you would know better than I do we really have a nursing shortage, or do we just have a pay problem?
We have a workplace condition problem. So when we surveyed, and then there was a follow-up survey out of the University of Michigan, we surveyed in 22. University of Michigan surveyed in 23 with a follow-up in 24, and nurses reported having left either the bedside, which is acute care, or the profession altogether due to working conditions that consisted of workload. So that potentially includes ratios. It includes a lot of other things. The use of mandatory overtime, the lack of resources, the lack of ancillary staff to help them do their job, because the nurse can do a lot of things. And so if I'm cutting my housekeeping staff, that room has to get cleaned, or we're putting a patient in a dirty room. Well, we're not going to let that happen. So then we step up and we clean that room. Right. And so now, the nurse can just do it. So we're not going to replace that housekeeper maybe. Our scope of practice is deep. We can draw blood, things like that. So it was those working conditions, the fact that they felt unsupported and not able to care for the patient. They were just a number to them. That's why nurses reported leaving the profession or leaving the bedside.
And I mean, I'm definitely agree with what you're saying. There was a particular piece that was in my sister's trach that needed to be replaced every, I think, 8 hours or something like that. I was the one who had to read up on that and find that information. And they did not have that at that hospital. So they had to run around to several hospitals to find that piece that was necessary. Right. But the nurses who work there knew this. I'm about Michigan. I'm about keeping Michigan people here and making sure we give them what they need to support them. So, that's where I'm at on this.
I think to that extent, too, a reminder that the compact does not create a new nurse. It shuffles nurses around.
Exactly.
So to that extent, maybe healthcare systems would be able to cross borders and staff with Wisconsin nurses, but are we stealing from, one to fix another in that moment?
Right.
And are we creating a problem then for that healthcare system that has the hospital across the border? This doesn't fix the staffing crisis. It just
I'm
moves
trying to
and
build here.
Yep,
That's my
moves,
goal.
and we're trying to build, right.
Thank you.
Thank you, Representative. Appreciate it. Thank all of you for being here and staying up here a long time on the table and testifying. We appreciate that. And next, we're going to move to Patrick Miller, Hospice of Michigan. And I know we're almost out of time, and we have committee members that need to get to other things. There's going to be a few people we're not going to be able to get to today in testifying, but we will bring them back next week if they're able to. I know we have some folks on Zoom, and hopefully they can come back because they're on Zoom and they can arrange it. But I want to apologize. It's never my intent not to get through everybody, and I will promise that we will have anybody that can't speak today come up and speak next week. Thank you again. Patrick, the floor is yours, and we look forward to your testimony.
Thank you, Mr. Chair. Members of the committee, appreciate the opportunity to testify. I will thin my comments. My name is Patrick Miller. I'm a proud graduate from the nursing school at Wayne State University in '96, started at Henry Ford. So I've been a nurse for almost 30 years. I am president and CEO of North Star Care Community, which includes Hospice of Michigan. We do hospice. We're not a hospital. We're a certain segment of care that is pretty unique, but we serve over 2,500 patients a day in Michigan. And as of yesterday, 37 children. It's end-of-life care, it's palliative, and it's very different. But for us, it's really important to have nurses who go to the bedside, who hold hands, who spend time with patients. I've done that. That's what our nurses do. That's what we ask them to do. And for us, I'm speaking in support of House Bill 4246. Not only has it been difficult to fill our open nursing positions, the Michigan Health Council's 2024 Healthcare Workforce Index reports that Michigan currently has a nursing shortage, and that will continue through 2033. I know many nurses have left the field. I want to address that, but it remains a challenge. For us, the opportunity to have the NLC would allow us to recruit from out of state. That would be a helpful thing. We recruit in-state, and for the positions that we have, our preference is to hire in Michigan. We're not always able to do that. And we have 17 locations. We're all throughout the Lower Peninsula, not in the Upper Peninsula yet. In addition, we provide clinical nursing triage after hours for 50 hospices in 18 other states and D.C. It's a very difficult segment of nursing care. And for us, our nurses have to be licensed in those states. So we have hired as many as we can. We've had to go out of the state and hire 60 nurses who live in 23 other states. We pay for their additional licensure. We take care of their CEs. If they work in other states where there are more requirements, they have to fulfill those, and we ensure all of that. But for us, if this is passed, for us the opportunity is to recruit and hire Michigan nurses. That's what we want to do. I'd rather have those 60 jobs be in the state. And again, we're not thousands and thousands of nurses. We've got 356 in Michigan, 60 out of the state. But for us and for the segment of the work that we do, it would be really, really special as we endeavor to be part of local communities. Our work is to be there as nurses and as others in the community, saying hi at church, saying hi at a grocery store, saying hi at a gas station. That's part of what we do. That's our fabric. And I would rather all of our workforce be here in Michigan. So I am here in support of the bill. I appreciate the opportunity to speak, and I'll take any questions.
Any questions from the committee? Representative Thompson?
Thank you. I know we're on a time crunch. How much of the hospice community is inpatient versus at home?
For us, we have an 18-bed inpatient unit in Kalamazoo. Everything else is where the patients live. So about half of that is in a facility, a nursing home or assisted living, an adult foster care, et cetera. The other half, roughly, is in private homes. Then there's quite a few that are in hospitals as well. But for us, we go to where they are, including bridges.
So your workforce is needed for homes as well, for patients to pass away at home?
All over, yeah.
And you need those nurses at home. Okay, thank you.
Representative Carter.
Thank you, Mr. Chair, and thank you for your testimony. I was sitting here thinking, and I want to clear this in my mind about a traveling nurse. That's a short-term or long-term assignment. What is it? They come in as needed, or both, or how's that function?
Yeah, we don't use traveling nurses, but where they are used, it's highly dependent upon the environment. We have organizations with whom we work in California where they're just a part of the figment of what they do, and then it varies depending on the organization. But we don't use traveling nurses, so I can't speak to that.
Okay, thank you.
Very good. Thank you very much. Seeing no other questions, I appreciate you being here. We are really, really tight and stuck on time here. I'm just going to ask a couple people that are still here. One I already know said that they could come back next week. Beth Scullin, you say that you need 3 minutes. That's about all I got, or would you be willing to come back next week?
I can do in 3.
Okay, come on up. President-elect ANA of Michigan.
You already.
In support of the bill and willing to speak to us today. The floor is yours.
Thank you so much, Chair and Committee. He's already introduced me. Bethany Campbell-Skillen. I am a nurse, and I am the president-elect for ANA Michigan. We represent nurses in all care settings, right? Next month, my son, Sam, graduates nursing school in Michigan, and he accepted his dream job in Colorado. So I'm super proud that he's joined our esteemed profession, and I'm excited that he gets to go live his dream. I would love to have him easily come back home and work in Michigan as well. There's a reason nurses are the most trusted profession. Have you folks been to a national conference? There is commonality and community when you get together with a bunch of nurses. We care about our patients. We don't care so much what state we're in. Lots of states have enacted the compact, and the sky has not fallen there. I love Michigan, but I'm not quite sure what makes us so different. Also, to answer your question from before, we are the 39th state in health outcomes. That's a problem. I would also like to address Rep. Whitsett and Rep. Carter about your personal experiences. As a nursing leader, that's on us. That's not about who the nurses are. That's about who is leading them in each of their facilities, who's training them, who's supporting them at the bedside. And if you had those experiences, I'm so very sorry, because that does not represent our profession as nurses and the sanctity that we experience in our patients' lives and in the lives of their families. So I'm sorry that that was your experience. But I do support this common sense policy that puts patient care, workforce support, and public safety first. And on behalf of ANA Michigan, I respectfully urge you to support Michigan's entry into the Nurse Licensure Compact to strengthen healthcare in our state.
Thank you very much. Any questions? Representative Carter.
Yes, brief correction on that. Our experience was very positive with the nurses who attended Christopher's Life.
Oh, good. I'm glad.
Okay, there was no issue with that.
I'm glad.
Thank you. All right, thank you very much. We're down to a couple minutes. I still have a couple pieces of business we have to complete. Sherry Martin, are you in the room? Sherry, question, how much time you didn't put that on the, or would you be willing to come back next week or come back on Zoom?
I would be willing to come back next week.
All right, very good. Thank you for that and accommodating. We want to make sure that you have all the time you need to do this. With that, we're going to go through quickly. We have some cards to read in. And if I mess up your name, forgive me. Todd Tennis, AFT of Michigan, not wishing to speak, opposing the bill. Not wishing to speak, opposing the bill, Sue Brown, United Steelworkers. Not wishing to speak, opposing the bill, Ryan Siebold, Michigan AFL-CIO. Not wishing to speak, opposing the bill, Leah Deere and Dina Carlissi, OPIU, Local 40. Not wishing to speak, opposing the bill, Stern Rezepa, AFS-CME. Not wishing to speak, opposing the bill, Mac Jones of Lara. Not wishing to speak, opposing the bill, Beth Bird, SEIU Healthcare of Michigan. Not wishing to speak, opposing the bill, Jeremy Gaez, Michigan Pipe Traders Association. Not wishing to speak, supporting the bill, Joan Bailey, Michigan affiliate of American College of Nurses. Not wishing to speak in support, Ashley Christian, Henry Ford. Not wishing to speak in support of the bill, Laura Haynes, Michigan Home Care and Hospice. Not wishing to speak in support, Dalton R. Herbal, Leading Age of Michigan. Shane Prestin, not wishing to speak in support of the bill, U.S. Department of Defense. Not wishing to speak in support of the bill, Jason Likowski, AARP. With that, Representative Hoskin moves to excuse absent members. With no objection, the motion prevails. There being no further business before the Committee of Health Policy, it will stand adjourned.